Hello everyone. So I welcome you all to this particular section. So this particular session, mainly it's a quick revision of the acute coronary syndrome, wherein I'll be quickly revising the topics of the NSTEMI and as well as the STEMI. So in both of these scenarios, that is NSTEMI and as well as STEMI, the common thing is they present with chest pain. And second important common thing is both of them, they present with the infarction, that is the death of the myocardium. So now the first important is the diagnosis. So if you see the diagnosis of the NSTEMI, what is all required for the diagnosis? First and foremost, very important point, there should be elevated cardiac biomarkers, that is troponin I and as well as troponin T should be elevated. And the very important point is there should not be any ST segment elevation in case of the NSTEMI. And just 1 minute. And the clinical presentations, if you see, these patients, they present with chest discomfort. Right? So chest discomfort, it is the common presentation in all the forms of the coronary artery disease. Either you take unstable angina or NSTEMI or STEMI or stable angina or the Prinzmetal angina, usually it will be a radiating pain. And this particular chest discomfort, it will be radiating to the left arm, shoulder, neck, or even to the jaw as well. That is what you'll observe in case of the NSTEMI. Now, if you see briefly about the history, what will be the duration of the chest discomfort in case of the NSTEMI? So the chest discomfort will be at rest, because in case of stable angina, what we discuss is, or what we describe is, the chest discomfort will be there on exertion in case of the stable angina. Whereas in case of the NSTEMI, the chest discomfort will be there at rest. And what will be the duration of this chest discomfort? The duration of this Hello. Muskan.
I was just requesting you to join the LRR.
Already started, no?
Okay, sir. Okay, thanks.
All right. I'm sorry. Right. So, yeah. So if you see the history, the duration of the chest discomfort will be more than 10 minutes. That is what you'll observe. Whereas in case of stable angina, like what we discuss is the duration of the chest pain will be around 5 to 10 minutes. And it will be like the crescendo pattern. As the time progresses, the duration of the severity of the pain will be progressing. And along with this chest pain, the other associated features that these patients will be having is the diaphoresis, right? Where there will be profuse sweating associated with the chest pain. And there will also be tachycardia, where there is increase in heart rate. And the hypotension will be there depending upon the severity of the NSTEMI. And if the individual goes into a state of the failure, there can be presence of S3 and even S4. And on auscultation of the lungs, you will also listen a bilateral crepitations, and that too basal crepitations. Now, in the ECG, what is that we have discussed? There will be ST segment depression. Now, how much should be that ST segment depression in case of the NSTEMI? So the ST segment depression, it should be more than or equal to 0.5 mm, right? It should be more than or equal to 0.5 mm, and that should be in the two contiguous leads. That is what is the criteria for the ST segment depression. And at the same time, there should also be T wave inversion. What should be the amplitude of the T wave inversion? The amplitude of the T wave inversion, this should be more than or equal to 0.3 millivolts. Okay, so ST segment depression of more than or equal to 0.5 mm in two contiguous leads, and T wave inversion of more than or equal to 0.3 millivolts is a criteria for the NSTEMI, right? And along with that, there will be dynamic STT changes that is suggestive of the ischemia. Now, if you see the details of the cardiac biomarkers which are being elevated, what is the most sensitive cardiac biomarker? The most sensitive cardiac biomarker, it is your cardiac troponin I, right? Now, they are observed in the blood within 2 to 4 hours, right? They are observed in the blood within 2 to 4 hours. And when do they reach the peak value? They reach the peak value within 12 to 24 hours. And they remain elevated for nearly around 7 to 10 days. Right? They remain elevated for nearly around 7 to 10 days. And these cardiac troponins, these are also the important markers for reinfarction. So whenever there is reinfarction, there is almost 20% quantitative increase in your cardiac troponin from the baseline value. And another important cardiac biomarker is the CKMB. This CKMB also is elevated and it reach the peak value within 24 to 48 hours and it will return to baseline within 72 hours. So by the end of the third day, this will return to baseline. Which one? The CKMB, right? Then followed by that, the imaging in case of the NSTEMI. So the imaging that we do is the coronary CT angiogram. See this coronary CT angiogram, what this will detect? So this will either detect the presence of the coronary artery disease or this will rule out the presence of the underlying coronary artery disease, right? Then we have what is called TIMI scoring system for non-ST elevation MI, the acute coronary syndrome, right? So in this particular TIMI score, what are the variables that we take? Let me show you. So, right. So if you see this, the variables that we take in the TIMI scoring system, they include the age of the individual more than or equal to 65 years, known case of the coronary artery disease, ST segment deviation more than 0.5 mm, that is ST segment depression, raised cardiac biomarkers, presence of the prior angina, right, more than or equal to 2 original episodes in 24 hours, and more than or equal to 3 coronary artery disease risk factors. These are all the risk markers in case of the TIMI risk score for NSTEMI. Now, if suppose, if the individual is having one risk factor, the chances of the cardiac event is 5%. And in the same way, if the individual is having 6 or 7 risk factors, the chance of the cardiac event is almost 41%. So this is about the TIMI risk score for NSTEMI. So in this table, if you observe, right. So in this table, the TIMI risk score. So the point is, more is your TIMI risk score, higher is the chances of the cardiac events, right? Then what are the other scoring systems which will assess the risk of recurrent acute coronary syndrome or mortality? So apart from the TIMI, we have the Grace scoring system and the other one is the Heart scoring system. So all these three, TIMI, Grace, Heart, these scores, they assess the risk of the recurrent acute coronary syndrome or even mortality. And when will you consider that the individual is said to be having the high risk? If suppose, if the TIMI score, if it is more than 3, this indicates the high risk. And these patients with TIMI score of more than 3, they require the PCA. That is, invasive strategy is required if the TIMI score is more than 3. And this is a very important question for the examiners, right? Then coming to the other treatment options. So in the treatment of the NSTEMI, you need to monitor for the ischemia, right? And you need to check for the ECG changes if there is any dynamic ECG changes. And you also need to monitor for the troponin, right? Now, if suppose, if there is ECG showing SC segment depression and the troponin levels are being elevated, then we diagnose that the patient is having NSTEMI. Now, what is the treatment in the acute phase of the NSTEMI? In the acute phase of the NSTEMI, the anti-ischemic drugs, which are very important, is the nitrates, next beta blockers, and then next important group are the AC inhibitors. So these are the anti-ischemic drugs as a part of the medical therapy in the acute phase. then we give statins and as well as the anticoagulants. And for the pain relief, right, for the pain relief, what is the drugs that we give? That is nitroglycerin should be given. And next important is the morphine. Right, next important is morphine if necessary. And the other important group of drugs for the pain relief is beta blockers, because beta blockers, they reduce the myocardial oxygen demand. So these are the treatment options in acute phase. That is anti-ischemic drugs, nitrates, beta blockers and ACE inhibitors, statins, anticoagulants, and the pain relief we give importantly the nitrates. Now, these patients with the NSTEMI, they are at high risk of development of the atrial fibrillation. Now, if at all, if they develop the atrial fibrillation in a clinical scenario of NSTEMI, what is the treatment that you need to give? So, NSTEMI patients with AF, they will require the anticoagulation. They will require the anticoagulation. And the anticoagulation that you need to give is, right, the anticoagulation that you need to give is like newer oral anticoagulants, right? Or you need to give warfarin, right? Or you need to give warfarin. Now, along with this anticoagulation, you also need to give the antiplatelet therapy, that is P2Y12 inhibitors. And what is that example of the P2Y12 inhibitors? That is clopidogrel. Okay. Now, these are the two things that you need to add, the anticoagulation and as well as the clopidogrel, P2Y12 inhibitor. And we also require the triple therapy in high-risk patients. I'll tell you about the triple therapy as well. Now, you take the invasive strategy. So what did we discuss? If the TIMI score is more than 3, they require the invasive strategy, right? So what is that you need to plan? Initially, when the patient comes, you give antiplatelets and as well as anticoagulants. Then followed by that, you need to do the coronary angiogram. This coronary angiogram should be done within 48 hours. And remember, in patients with NSTEMI, we don't thrombolize the patients. So coronary angiogram should be done within 48 hours for the high-risk patients. So how will you assess the risk? That is by TIMI score, which already I have said you. Now, once you do the coronary angiogram, depending upon the coronary angiogram abnormality, we can plan either the PCI or the CABG. That is based on the anatomy of the coronary arteries, right? And in low-risk patients, you don't require the invasive strategies. In low-risk patients, the conservative approach is enough, right? In low-risk patients, the conservative approach is enough. So that is for the invasive strategy in case of NSTEMI. Then what is the long-term management that you will be doing in case of the NSTEMI? That is the lifestyle modifications. What will be that lifestyle modifications? Very important is if the individual is a smoker, smoking cessation has to be advised. Then diet. Okay, so the diet restricted with fat should be advised. And the individual is advised the permissible exercise for that particular patient. And next important is the blood pressure control. Next is the glucose control. And at the same time, you also need to maintain the LDL. And how much should be that LDL levels? The LDL levels, it should be less than 55 milligrams per deciliter, right? LDL level should be less than 55 milligrams per deciliter, okay? And in high-risk patients, right, in high-risk patients, they will be requiring prolonged dual antiplatelet therapy. Now, what will be this dual antiplatelet therapy? That includes the clopidogrel, and the next important is the aspirin. So prolonged DAPT is required in high-risk cases. Then followed by that, invasive and as well as the conservative strategy. So what is that invasive approach? The invasive approach is the coronary angiogram followed by that the PCA. That is the invasive approach. So this improves the outcome mainly in high-risk patients, right? In high-risk patients where the risk stratification is being done in the form of with the help of the TIMI score. Next is the conservative strategy. So conservative strategy here, medical management alone. And this conservative strategy, it is mainly for low-risk patients. right? It is mainly for the low risk patients. Okay, that is about the invasive versus so invasive strategy in high risk, whereas conservative strategy in low risk patients. If the TIMI score is less than 3, then the conservative strategy is required. If the TIMI score is more than 3, then the invasive strategy is required. Then I was discussing about the triple antiplatelet therapy. So now, what is this triple antiplatelet therapy? That includes the aspirin, then P2Y12 inhibitor, and the anticoagulant. This is what is called the triple antiplatelet therapy. Now, where is this used? This is used if the patient with NSTEMI, he's having atrial fibrillation and there is high thrombotic risk. Right? If there is high thrombotic risk, then in such cases, you need to give the triple antiplatelet therapy. But please remember, this triple antiplatelet therapy, there is increased risk of bleeding. So this triple antiplatelet therapy, you need to give for a short period of time. Then followed by that, the anticoagulants. Now, what are the anticoagulants that we give? The anticoagulants are the unfractionated heparin, low molecular weight heparin, and then the fondaparinux, then the direct acting oral anticoagulant drugs. What are these direct acting oral anticoagulant drugs? That is apixaban and as well as rivaroxaban. So the advantage of giving this, the anticoagulants, is they reduce the thrombotic complications. Right? The advantages, they reduce the thrombotic complications. That is the advantage of giving this, the anticoagulants. And which particular anticoagulant should be given? It all depends upon the renal function and as well as the bleeding risk. And if you see the detailed treatment of the atrial fibrillation patients with NSTEMI, they require direct oral anticoagulant drugs, right? Or you need to give warfarin. Okay. AF patients with NSTEMI require the direct oral anticoagulants or the warfarin, and that should be combined with the antiplatelets. Now, whether to combine with antiplatelets or whether to give anticoagulants, it all depends upon the CHA2DS2 VAS scoring system. So, if the CHA2DS2 VAS scoring system is 0, right, you don't require to give any, here we give antiplatelets, right? And if the CHA2DS2 VAS scoring system is 1 in a case of NSTEMI, then you should give either antiplatelets or anticoagulants. And if the score is 2, then definitely you need to give anticoagulants, right? Now, so coming to the duration of the DAPT in patients with NSTEMI. For how long you need to give the DAPT? That is aspirin plus P2Y12 inhibitor. See, this DAPT, it is a standard for the NSTEMI. For how long you need to give? You need to give for nearly around 12 months. Right? You need to give for nearly around 12 months. Okay. Right. Then, yes, Alina, what is the duration of the triple therapy? So the duration of the triple therapy, it should be given for 1 to 2 months. Right? And what is the reason? Because there is increased risk of bleeding. Because there is increased risk of bleeding. Okay. Next. Now, whereas dual antiplatelet therapy, that should be given for nearly around 12 months if PCI is performed. If PCI is performed, the DAPT should be given for nearly around 12 months, right? Whereas in selected high-risk patients, right? In selected high-risk patients, they have to, this triple therapy, DAPT should be given even for up to 3 years as well. Okay, so this is about the DAPT in case of the NSTEMI cases, right? Now, you need to know the trials in patients with the NSTEMI. So the trials, one of the very important trial is the TIMI trial. The TIMI trial is done for what? The TIMI trial, this is mainly done for assessment of the risk stratification. Next is the Plato trial. The Plato trial has compared ticagrelor versus clopidogrel, and this said the ticagrelor is more efficacious than compared to that of the clopidogrel. Then we have Q trial. This Q trial, it said about the DAPT benefits, and it said that DAPT should be given for nearly around 12 months, and in high risk cases, you need to give for 3 years. Then the next important is the ISAR or ISAR REACT trial. So this ISAR REACT trial, this has compared the prasugrel versus ticagrelor in acute coronary syndrome. And next is the COMPASS trial, where it has said the role of rivaroxaban in patients with the coronary artery disease. So these are the trials in case of the NSTEMI, right? So to summarize the treatment of the NSTEMI, right? To summarize the treatment of the NSTEMI, what is the initial treatment? The initial treatment, the aspirin should be given. Aspirin should be given. Then followed by that, you need to add the P2Y12 inhibitor, which is more preferred. Ticagrelor is more preferred than compared to that of the clopidogrel in patients with NSTEMI. Then anticoagulants, that is your low molecular weight heparin, or the unfractionated heparin, or the fondaparinux, right? And at the same time, if the individual is high risk, then you also need to consider glycoprotein 2B3A receptor inhibitors, which includes either eptifibatide or the tirofiban. So this will be the initial treatment. Now, within 48 hours, right? Within 48 hours, what is that you need to plan for? You need to plan for the coronary angiogram, right? Now, if the coronary angiogram shows low risk during hospitalization, you need to give aspirin, P2Y12 inhibitor, and then anticoagulation. Now, if suppose you have done a PCI where the TIMI is showing like TIMI risk is showing like more than 3, you have done a PCI, there you need to give aspirin, P2Y12 inhibitor, anticoagulant, and again you need to consider the glycoprotein 2B3A receptor antagonist if the individual is in the hospital. Now, what is that you need to do at the time of discharge? At the time of discharge, the DAPT therapy should be given for 12 months, either medically treated patients or even the PCA treated patients. The DAPT therapy should be given for nearly around 12 months, and that is the class of recommendation 1, right? Class of recommendation 1. Okay, so this is about the summary of the NSTEMI. This is about the summary of NSTEMI, right? Now, after having discussed about the NSTEMI, now let me just quickly summarize about the STEMI, right? So the presentation is the same. What is that presentation? That is a chest pain. Now, so if you take the investigations, that is the ECG first, right? Now, what is the earliest ECG change in patients with STEMI? Any one of you, please? What is the earliest ECG change in patients with the ST elevation MI? Earliest ECG change in patients with ST elevation MI. So, the earliest ECG change in patients with ST elevation MI, yes, can anyone answer this? So please remember, it is not ST segment elevation as the earliest ECG change. The earliest ECG change in patients with MI will be broad, tall T wave. Right? Broad, tall T wave. That is the earliest ECG change in patients with the MI. Then followed by that, you will have the ST segment elevation. And this ST segment elevation, this should be more than 2 mm in the chest leads, right? Or it should be more than 1 mm in the limb leads, right? And it should be in the 2 contiguous leads. Minimum, it should be in 2 contiguous leads. Then after tall T wave and ST segment elevation, once there is an infarction, once there is transmural infarction, then there will be appearance of the Q wave. Once there is transmural infarction, there will be loss of the R wave. Once there is transmural infarction, there will be loss of the R wave. So this will be the ECG changes. So in patients with STEMI, you will have dynamic ECG changes. Then followed by that, the troponins. The troponins are being elevated. And which is the preferred biomarker in early STEMI? This is your troponin I. It is not troponin T, it is troponin I. That is the preferred preferred biomarker for early STEMI. Now, what is the upper limit of the troponin I? So the upper limit of the troponin I is, the value is 0.04 to 0.06 nanogram per ml. This is the upper limit of the troponin I. Whereas you take troponin T, this is used for monitoring the ongoing cardiac damage. And the normal value of your troponin T will be 0.01 to 0.04 nanograms per ml. Right, that is troponin T. And next is the CKMB. So CKMB, it is less specific than compared to that of the troponins, right? And this CKMB, what is the upper limit, right? So you take in case of males, right? So in case of males, the upper limit of the normal value will be 5 to 25 units per liter, whereas in females, the value will be 5 to 15 units per liter in case of females. That is about the CKMB, right? Then followed by that, so in the investigations of STEMI, one is your ECG first, then the cardiac biomarkers, then next is the cardiac imaging. So in the cardiac imaging, the echocardiography is the first line cardiac imaging. What is the purpose of doing the echocardiography? So this will detect the wall motion abnormality. This will tell you about the LV function, and this is also useful for the prognosis. And next is the MRI, that is gadolinium contrast MRI, right? So what we do is late gadolinium enhancement. Now this MRI, it will highlight the infarct zones, right? The importance of the MRI is this will highlight the infarct zones, and this MRI will be able to differentiate the infarct zone from the normal myocardium. That is the importance of the cardiac imaging. That is your gadolinium enhanced MRI. So gadolinium enhanced MRI highlights the infarct zone from the normal myocardium. And the next important cardiac imaging is the myocardial perfusion imaging, that is MPI. What this will identify? This will identify the myocardial blood flow abnormalities. But the point is, this myocardial perfusion imaging will be able to detect the myocardial blood flow abnormalities, but it cannot, right? But it cannot differentiate. It cannot differentiate acute versus chronic MI. Right? It cannot differentiate acute versus chronic MI. Right? The next important cardiac imaging is radionuclide ventriculography. What is the importance of this radionuclide ventriculography? This will show the wall motion abnormality, and this will also be able to detect the ejection fraction. So this will also detect reduced ventricular ejection fraction. Right, this will also show if there is any reduced ventricular ejection fraction. That is the importance of the radionuclide ventriculography. And another important imaging is the SPECT, that is single photon emission computed tomography. What is this useful for? This is used for myocardial perfusion imaging, and this will detect the areas of reduced blood flow. Right, this will detect the areas of. So this will detect the areas of reduced blood flow, but this SPECT, it lacks specificity for acute MI, right? It lacks specificity in cases of the acute MI. Next important cardiac imaging is PET. So this particular PET, it provides metabolic imaging of the myocardial viability. And what is the importance of this PET is, definitely it will tell you about the metabolic imaging of the myocardial viability. And this PET, it will distinguish between, right? So this will distinguish between viable and non-viable myocardium. Right? Viable and non-viable myocardium. That is the importance of this particular PET scan. So if you see all this cardiac imaging now, so one is your echocardiography. This will detect the wall motion abnormality, LV function, and it is useful for prognosis. MRI with gadolinium contrast, this will highlight the infarct zone, and this will identify, or it will differentiate the infarct zone from the normal myocardium, MRI. Next is myocardial perfusion imaging. This will identify the myocardial blood flow, right? But it cannot differentiate acute versus chronic MI. Next is radionuclide ventriculography. This will show if there is any presence of the wall motion abnormality and reduced ventricular ejection fraction. Next is SPECT. It is used for myocardial perfusion imaging, and this will detect the areas of reduced blood flow, but it lacks specificity for acute MI. Next is PET, that is positron emission tomography. This will provide metabolic imaging of the myocardial viability, and this helps to distinguish between viable and non-viable myocardium. That is your PET. Next important is in patients with the ST elevation MI, there are some non-specific indices like WBC count. WBC count, it is increased, right? It is increased after the myocardial infarction onset. So it may reach from 12,000 to 15,000 cells per microliter. And this elevated RBC, this will persist for nearly around 3 to 7 days. Right, so this will persist for nearly around 3 to 7 days. Okay, and another important non-specific indices is the ESR. ESR, it rises gradually and it peaks in the first week. Right, it will reach the peak value in the first week, and this remains elevated. The ESR remains elevated for nearly around 1 to 2 weeks. Right, for nearly around 1 to 2 weeks. So this is about the workup or the investigations in patients with the ST elevation MI. Now, let me discuss in detail about the treatment of the ST elevation MI. So the same thing, what is the initial management? What is the pre-hospital care? What is the management that we do in the emergency department? How will you control the chest discomfort? All that I'll discuss now. So first important, the initial management and thrombolysis. See, the outcome of the patient with STEMI, the prognosis of the patients with STEMI, it completely depends upon the electrical complications, that is arrhythmia, and mechanical complications, that is the pump failure. Mainly, if the individual develops the electrical complications like ventricular fibrillation within the first 1 hour, right? Ventricular fibrillation within first 1 hour. This is the most common cause of death. Right? This is the most common cause of death. And what is the pre-hospital care that you need to give? The pre-hospital care is first and foremost early symptom recognition, rapid emergency response, right? And if you do a pre-hospital fibrinolysis, that will reduce the mortality rate in patients with the STEMI. And in the emergency department, what is that you need to do? First and foremost, you need to give aspirin. That is, the individual has to chew that. Next is oxygen. If the individual is hypoxemic, nitroglycerin has to be given, but you should avoid giving nitroglycerin if the individual is having hypotension, or if the individual is having right ventricular infarction, you should avoid giving this nitroglycerin. Right, and very, very important is the early reperfusion is very much crucial. Early reperfusion is very much crucial. Now, the control of the discomfort. Control of discomfort, the individual is having severe chest pain. So what is that you need to give? Sublingual nitroglycerin should be given. Right, sublingual nitroglycerin should be given. That is mainly for pain relief, right? But if the pain is so severe, then morphine should be given. Right, if the pain is so severe, morphine, but you should be very cautious about hypotension. Morphine can cause hypotension, so you should be very cautious for that. Right, and another important group of drugs are beta blockers. So these beta blockers, they reduce the reinfarction. The advantages, they reduce the reinfarction, And at the same time, they will also reduce the arrhythmias. That is the advantage of giving the beta blockers, right? Then next is the management strategies. So this is like the initial thing is the initial management and thrombolysis, pre-hospital care, and emergency department. What is that you need to do, and how is that you need to control the chest discomfort? Now, okay, management strategies, right? Once the patient comes to the emergency department, first and foremost, the 12-lead ECG is the primary triage tool, right? And the patients with ST segment elevation, as I have said you, immediately they need to be given the reperfusion therapy, that is PCI or thrombolytic therapy, right? And how will you limit the infarction size? So you will be able to limit the infarction size by the restoration of the coronary flow, and at the same time, reduction of the myocardial oxygen demand. Right, reduction of the myocardial oxygen demand, and at the same time you should also treat the ischemic penumbra. That will improve the outcome. Next is the fibrinolysis, and fibrinolysis should be given within 30 minutes. Within 30 minutes, the fibrinolysis should be within the 30 minutes of the hospital arrival, right? And the TIMI flow grading system that will assess the reperfusion success. Now, what is this TIMI flow grading system? See, in the TIMI flow grading system, you have 0, 1, 2, 3, right? 0 means it's a complete occlusion of the vessel. TIMI 1, there is minimal perfusion across that coronary artery. And TIMI 2, there is partial perfusion with slow flow. And TIMI 3, there is full perfusion, normal flow. So it is your TIMI flow grading system that will assess the reperfusion success. And whenever you're giving the fibrinolysis, what are the fibrinolytic agents? That is tissue plasminogen activated, which is altiplase, right? Which is altiplase. And what is the dosage of this altiplase? 15 milligrams. You have to give 15 milligrams. You have to give bolus. Then followed by that 50 milligrams over 30 minutes plus 35 milligrams over 60 minutes. That is altiplase. Next is streptokinase. 1.5 million units is what you need to give over 60 minutes. Next is tenecteplase. Tenecteplase, it is considered as a best thrombolytic agent. Right? It is considered as best thrombolytic agent. And dosage of tenecteplase is the single bolus, and that should be given at a dosage of 0.53 milligram per kg. Next is retiplase. Retiplase, you need to give 10 milliunits or 10 million units, and that should be given bolus. And again, after 30 minutes, you need to repeat again. So 2 doses should be given of 10 units. Now 10 units bolus. After 30 minutes, another 10 units. So that is about the dosage of the fibrinolytic agents, right? So once you do a PCA or once you give a fibrinolytic agent, you should be able to do the TIMI grading system. Now you should know the contraindications for the thrombolytic therapy. So the absolute contraindications, if the individual had a prior hemorrhagic stroke any time in the past, it's an absolute contraindication, right? Or if the individual had the ischemic stroke within the past 1 year, it's an absolute contraindication. Or if the individual is having the aortic dissection, it is also an absolute contraindication. And if the individual has active bleeding, then also it is an absolute contraindication. Then what are the relative contraindications? The relative contraindications are if the patient is having uncontrolled hypertension. And what should be that uncontrolled hypertension? That is more than 185. It's a relative contraindication. More than 185 by more than 120. Pregnancy, it's a relative contraindication, right? Or the individual has undergone a major surgery within the last 3 weeks. That is the relative contraindication. So these are the contraindications for thrombolytic therapy. And what are so once you have done the PCI or once you have given the thrombolytic agents, right, fibrinolytic agents, these patients have to be continued with the antithrombotic agents. What are these antithrombotic agents? That is aspirin plus P2Y12 inhibitor, that is clopidogrel, prasugrel, or ticagrelor, right? And in those individuals who have undergone the PCI, in them, they may require glycoprotein 2B 3A receptor antagonist. So in PCA patients, they require glycoprotein 2B3A receptor antagonist, right? Then, or the other drug that you should give is the unfractionated heparin or low molecular weight heparin. Now, if at all, if you're giving unfractionated heparin, then the dosage of the unfractionated heparin is 60 units per kg bolus, then followed by that 12 units per kg per hour infusion should be given. And if at all, if you are giving enoxaparin, the dosage is 1 milligram per kg subcutaneously every 12th hourly. And if you are giving fondaparinux, 12.5 milligrams subcutaneously daily should be given. And if you are giving this bivalirudin, intravenously should be given alternative to unfractionated heparin for PCI patients. So this is the details of the antithrombotic agents and their respective doses. Then coming to the beta blockers. So you should give immediate IV beta blockers mainly to reduce the infarct size, right? Mainly to reduce the infarct size. And at the same time, it will not only reduce the infarct size, it will also reduce the ventricular arrhythmias like VT and as well as VF. That is like the purpose of giving intravenous beta blockers. And at the same time, the beta blockers also have to be given for long term. So the long-term beta blockers, they prevent the reinfarction, right? They prevent reinfarction and they also improve the survival. Right, they will also improve the survival. So that is about the beta adrenoreceptor blockers. Now, is there any role of the ACE inhibitors? Yes. So the ACE inhibitors, they will lower the mortality. Particularly in high-risk patients, the ACE inhibitors are very, very important. And if the individual is not tolerating the ACE inhibitors because of the dry cough, in those patients, the angiotensin receptor blockers should be given. And do we need to give aldosterone antagonists like spironolactone? Yes. Spironolactone, it should be given in those individuals with LV ejection fraction less than or equal to 40%, right? If the LV ejection fraction is less than 40%, with diabetes or heart failure, then in them spironolactone should be given. And what are the other agents which are very, very important? That is IV nitroglycerin, that is mainly for controlling the pain, right? And calcium channel blockers, very, very important in case of STEMI, they are not recommended. And what is very, very important is the strict glucose control with the help of the insulin, right? And next is you need to maintain the adequate levels of serum magnesium that will reduce the mortality. That will reduce the mortality. Okay. And between the PCA and thrombolytic therapy, which is more preferred, the PCA is preferred over the fibrinolysis. Now, whenever if you are doing the fibrinolysis, if suppose if the fibrinolysis is failed, then rescue PCA should be done. Right? Rescue PCA should be done for failed fibrinolysis. Right? So this is about, and this PCI should be done within 90 minutes of the arrival into the hospital. So this is about the PCI. Right? And the next important is the trials in patients with STEMI. So if you see the trials in patients with STEMI, one is the TIMI trials, that is for risk stratification, right? Next is the GUSTO trial, that is mainly to assess the efficacy of the fibrinolytic agents. Then COMET trial, that is mainly the impact of the beta blockers or morphine. Then OASIS trial, that is mainly the role of fondaparinux in STEMI. Next is Plato trial, where there was a comparison of ticagrelor versus the clopidogrel in the acute coronary syndrome, which said that ticagrelor has the higher efficacy than compared to that of the clopidogrel, right? So this is about, these are the major clinical trials. So I've said you about the trials in NSTEMI, and these are the trials for STEMI. Now, so this is about the detailed discussion of your NSTEMI and as well as STEMI. Now, let me discuss some of the multiple choice questions. right? So the first question, I want every one of you to actively participate in this discussion. We have a 58-year-old male presented with 45 minutes of substernal chest pain radiating to the left arm. ECG shows STEMI in leads V2 to V5. What is the next best step in this management? Administer aspirin and start heparin, then observe. Immediately do coronary angiography with PCI. Give morphine and beta blockers, then reassess in 6 hours. Start nitrates and send for the stress test, right? So immediately you need to do PCI because the individual is the one with the STEMI, that is ST elevation MI. So in patients with ST elevation MI, you need to do immediate coronary angiography with PCI. And this PCI should be done within 90 minutes. Next, which of the following is the absolute contraindication to fibrinolysis in STEMI patients? Absolute contraindications. Yes. Yes. So if there is active internal bleeding, except menstruation, right? Except menstruation, that is the absolute contraindication. And the other absolute contraindications I have said you, that is history of the hemorrhagic stroke any time in the past, right? Or history of ischemic stroke within the last 1 year, right? Or the individual having suspected aortic dissection and the individual had undergone a major surgery in the last 3 months, right? These are all the absolute contraindications. Next question. A 65-year-old diabetic patient with NSTEMI is started on the DAPT. Which combination is preferred? Aspirin plus prasugrel, clopidogrel, ticagrelor, or clopidogrel plus warfarin? Yeah. See, in patients with thrombocytopenia, what is that we need to do is we need to quantify the risk versus, right, risk versus benefit. If the platelet count is around 1 lakh, then you can do thrombolysis without any problem. Okay. Yeah. So here the preferred combination in patients with NSTEMI is aspirin plus ticagrelor, because so this was according to your Plato trial. What did the Plato trial tell you? The Plato trial said you it is ticagrelor which is being highly efficacious than compared to that of your clopidogrel. Okay, the name of the trial is also very, very important, right? Next, a 72-year-old patient presents with STEMI but is at a hospital without PCI facilities. What is the next best step? Immediately fibrinolyze with tenecteplase, transfer to PCI capable center within 3 hours, perform stress test before deciding on intervention, start beta blocker and manage medically. Yeah, so if the PCI facility is not there, then you need to do thrombolysis first. Okay, so thrombolysis is the earlier management in this patient, right? Not shifting the patient where the PCA facility is available. Okay, next question. Right, 60-year-old male with NSTEMI is scheduled for coronary angiogram or angiography. Which anticoagulant is preferred? Which anticoagulant is preferred? Right, that is the unfractionated heparin. Unfractionated heparin is a preferred anticoagulant in PCI. Why? Because it has rapid onset of action, and at the same time, it also has the reversibility. Right, at the same time, it also has the reversibility. Right, next. A patient with history of STEMI is discharged on aspirin, beta blocker, atorvastatin, and an ACE inhibitor. What additional medication should be considered if he had diabetes and ejection fraction of 35%? right? Yes. So what is that we have discussed? If the ejection fraction of the individual is less than 40% in a patient with STEMI, you need to add the aldosterone antagonist, right? So what this will do, this will prevent the cardiac remodeling and it will reduce the mortality in the patient. And it will reduce the mortality in the patient. So either spironolactone or the eplerenone. That is what you need to add in post-MI patients if the ejection fraction is less than 40% and at the same time the individual is diabetic. Yeah. A 50-year-old patient with history of atrial fibrillation develops the NSTEMI. What is the preferred anti-thrombotic strategy? AF develops NSTEMI. 50-year-old individual. What is the preferred strategy? Yes. So, in case of NSTEMI with atrial fibrillation, you need to give the triple therapy. And what is the triple therapy? That is aspirin, P2Y12 inhibitor, that is your either clopidogrel or ticagrelor, then you need to add the anticoagulant. So this is recommended for AF with NSTEMI with a shorter duration. Why? Mainly to reduce the risk of bleeding. To reduce the risk of bleeding. Next, in the management of STEMI, which of the following has the strongest mortality benefit? Which of the following has the strongest mortality benefit? No. It is not the beta blocker. In patients with STEMI, please remember it is the aspirin. It significantly reduces the mortality in patients with STEMI. Right? Significantly reduces the mortality in patients with STEMI. How? By inhibiting the platelet aggregation and reducing the thrombotic complications. So the answer is the aspirin. See, I'm not asking in case of heart failure. In case of heart failure, yes, the answer is your beta blocker. But this is a scenario of STEMI. The answer is the aspirin here, right? But there is a very high scope that you may answer this beta blocker, but it is not beta blocker. Next. A 68-year-old STEMI patient undergoes successful PCI and he started on DAPT. So how long should he continue DAPT? How long should he continue DAPT? I've said in the same discussion. Right. So he has to continue aspirin plus clopidogrel for a duration of, or even ticagrelor for a duration of 12 months. Followed by that, the single antiplatelet therapy should be continued, that is aspirin. Okay, right. Last question. A patient receives streptokinase for STEMI but does not show ST segment resolution after 90 minutes also. What is the next step? What is the next step? Right. So the next step here is, right. So the next step is you need to perform the rescue PCI. So what is this now? This is your failed thrombolysis. Right. So this is your failed thrombolysis. Where, what do you mean by the word failed thrombolysis? Where there is lack of the ST segment resolution. And this requires immediate rescue PCI for better outcomes. Okay. So this is about the quick revision of the NSTEMI and as well as the ST elevation MI, right? So tomorrow we have the another important session at 6 p.m., right? Wherein I'll be discussing the topic in a very concised and summarized manner, and followed by that we will be doing the multiple choice questions tomorrow also. So tomorrow's session will be at 6 p.m. and this PDF will be attached to the this video, wherein you can download and then you can revise just before going to your exams also. And if you have any doubts, you can just text me on the chat box. I'll be definitely happy to answer your questions. right? Not only now, even later also, you can just text me in the chat box of the same video. I will be very happy to answer your questions, right? So thank you very much, and I'll wind up this session.